No excuse for that. Nothing I can do. You're not taking your time. All right. So let's go on. Now we're going into aerosol and humidity. So this one is going to kind of overlap with the one you just did, right? The high flow systems. Not going to really talk about the low flow systems in this unit, but we're going to talk more about the aerosol and the humidity that the body needs. We said that the nose is the magic part of the body that provides the humidity and the temperature we need for our alveolar gas. The alveolar gas is exerts 47 millimeters of mercury of water vapor, right, which is humidity, okay? Well, that water vapor, we're going to talk about where we got that water vapor from and how much water is that, right? We got the pressure that it holds, but how much water is actually in that water vapor? We're going to learn what that is and how we got to that, okay? Remember, I always told you that temperature is very, very important when you're dealing with humidity and gases. The temperature makes a difference of how much water can that gas hold, right? The colder it is, the more water comes together and drops, all right? The warmer it is, the more humidity it can actually provide. Being in Memphis, Tennessee, it's always very humid in the summer, right? So not only is it hot, but it's humid. You can feel the stickiness of the heat, right? Whether in the shower or the shade or direct sunlight, it's wet. It's a wet, sticky, hot, humid feeling because where we are, the gas in the atmosphere has a very high humidity. Okay, if you go somewhere like California or Arizona, it's hot, right? It can be hot in the summer and it can be way hotter than it is in Memphis, but it's a dry heat. It's less humid, okay? And so if you go into the shade, you're not as hot. You don't feel sticky if you're in the shade. It's still hot outside, but it's a difference between being in direct sunlight and being in the shade, okay? But in Memphis, you can't escape the humidity, all right? And so we're going to learn a statement about alveolar gas and as it pertains to its humidity, okay? I'm going to say it now. Let me see. Write it on the board for you. This is a true statement. Everything goes from here. I'm black marker. All right. This is a true statement about alveolar gas. Alveolar gas. There's a true statement about alveolar gas. Every breath that you take in your body we talk about temperature being very important. So at 37 degrees Celsius, alveolar gas is considered to be 100% relative humidity. Relative humidity. RH stands for relative humidity. Okay? It holds 44 milligrams of water. And that 44 milligrams of water exerts a pressure of 47 millimeters of mercury. Okay, that's where we get the 47 from. That's the pressure of water vapor. Pressure of water vapor is 47 millimeters of mercury. Well, you say, well, how much is that? Well, it's actually 44 milligrams of water. Okay, 44 milligrams of water in that vapor. Okay, and it exerts a pressure of 47 millimeters of mercury. Now, relative humidity. How do we get relative humidity? Relative humidity is, I think it's absolute potential, but let me make sure. Hold on. Is it? Okay. It was on my shoulder, my cheek so fat. All right, so relative humidity, make sure I write it down right. Pretty sure I knew it, but I don't want to tell you wrong. There we go. Absolute humidity divided by relative. Relative humidity, also known as potential. Okay. Oh. Yeah, relative. Potential, also known as capacity. That's right. This is also known as capacity. Capacity of the gas times 100. Okay, it's going to be expressed in a percent. Answer is in a percent. So percent relative humidity equals absolute humidity over potential humidity. Potential is also known as the capacity, the ability of the gas, right? Just because it has the capacity to hold a certain amount don't mean it's holding, okay? Just because at 37 degrees, a gas has the capacity or the potential to hold 44 does not mean that it's going to be holding that 44, okay? The absolute humidity is what you got.
Come help us out. I need a tutor.
All right. Absolute is also known as what you got. Okay? What you got. All right? You can put that in parentheses on your note is what you got. What do you have? All right? What do you have? Now, potential is what you're supposed to have. All right? What you could have. So if I told you you had the potential to have $100 in your pocket, but if I check your pocket and you're only holding $50, Then the 50 is the absolute. That's what you got in your pocket. You're supposed to be able to hold 100, but you're only holding 50, right? So what percent do you have? 50%. So your relative humidity is 50%. Okay? So if a gas has, for example, so I hope y'all wrote that down because I'm going to have to erase it. All right. This is a true statement about alveolar gas. Make sure you never forget it. Highlight that, put it somewhere where you never forget it. Because the nose, the magical nose is what does that. It heats the gas up to 37, right? Because that's body temperature. And the mucosa and the nasal concha moisten it up to 44 milligrams, right? Every breath hits that, okay? So the reason why it's 100% relative humidity is because this is the formula. So what's the relative humidity of alveolar gas? Well, it's holding 44 milligrams, and it has the capacity to hold 44 milligrams at 37 degrees Celsius. Okay, so at 37 degrees Celsius, it has the potential or the capacity to hold 44, and it's holding 44. So 44 divided by 44 is what? Times 100 is 100% relative humidity. When something is 100% relative humidity, it's also known to be, let me make sure I stop the share so people can see it. Oh, you probably could. Okay. Okay. This is also known as saturated. It's fully saturated, right? If you are standing in some water up to your waist, are you 100% saturated or half? Half, right? But if you go all the way into the water, now you are 100% saturated. Okay? Well, the humidity or the water vapor at 37 degrees Celsius has the capacity to be 44 milligrams. And when we check it, it is full. It's 44 milligrams. So it's completely saturated, or a relative humidity of 100%. No. Alveolar gas is, but other gases not necessarily. Just depending on the temperature. Question.
So this determines how saturated something really is.
This is going to determine how saturated a gas is at a given temperature. So when you check the weather and they talk about the barometric pressure, they also talk about relative humidity. That's what they're talking about. So for instance, this is just for instance now. Let's do a call. Let's just say the weather said that at 80 degrees Fahrenheit, gas has potential to hold, let's say, 200 milligrams of water. Okay? You check it, and the absolute humidity is 100 milligrams of water. Relative humidity today is 50%. 50%. All right. What if I said at 60 degrees Fahrenheit, gas has the potential to hold 60 milligrams of water, and the absolute humidity is 30. Oh, no, not 30. 20 milligrams of water. Relative humidity would be how much? 30%? Well, 60 is the potential. Absolute is 20. So 20 divided by 60 times 100. 20 divided by 60, 33%. 33%. That's all it is. That's relative humidity. Absolute is what you got, right? What do you have in your pocket right now? That's your absolute. What you're supposed to have is something different, okay? This is how you find relative humidity, and it makes a difference with the temperature. Now, there's a trick that you're going to learn when we get to the notes. As the temperature goes up, the relative humidity can go up. But as the temperature goes down, the relative humidity stays the same. Okay? And they're going to find out why today. All right? It stays the same. All right, so let's get to the notes. All right, so that's relative humidity. I gave you the statement on alveolar gas. That's very, very, very important to understand that, okay? Because we need to know what the nose is doing. They call it the magical nose. Without your nose, you can't do these things. So we have to do them, right? That's why we put them on aerosol face masks, aerosol T-piece, aerosol trait collar, right? Because if they have a trait, then the nose has been bypassed. If your patient has an artificial airway, whether it be a ET tube down the throat or a tracheostomy, then they're bypassing the nose. And so the nose is no longer being used. So that means we can't heat it, we can't moisten it. Okay, so it means we as respiratory therapists have to do it for it. We have to do the job of the nose. And so we have several different types of humidifiers and nebulizers that can do this job. Okay, and so that's what you want to learn mostly about what happens if you don't have the correct amount of humidity, what happens in the lungs. It's a domino effect. You wouldn't think that just not having the humidity could lead to such dire instances. Okay, pneumonia, death, all that can happen with lack of humidity. Some things can also happen when I put humidity on some person who hasn't had humidity. Okay, you'll learn about that. You're going to learn that some people's airways are hyper responsive, right? Hyper reactive. So any little water particles that they inhale can make the airway just close up on them, called bronchospasm. Okay, that can happen. Very rarely does that happen, but some people have very, very reactive airways. Somebody with too much perfume on, or somebody with too much lotion on, or something like that. And you walk in a room with too much of that on, and you just instantly have an asthma attack. Okay, because your airways are hyper reactive to anything other than just regular air. Okay, and so that can happen as well. All right, so let's go to the notes. Lesson plan. All right. Quick objectives. All right, student will be able to. Yeah, that's it. Make it a little bit bigger. Demonstrate proper setup of humidifiers with high flow and low flow devices. Flow, oh, that should have been a 2. Given situations, discuss humidity deficit and prevention. Given indications for humidity. What are the indications for humidity, right? Discuss the factors that influence the efficacy or efficiency of humidifiers. What makes one humidifier better than another one, okay? Given a situation like you just did, calculate the RH, which is relative humidity. Just did that, all right? Discuss problems with the humidity deficit. Discuss hazards of humidity, because anything too much of it is bad for you. So somebody can have too much humidity, right? You can put too much water into the system. Demonstrate bronchial hygiene methods. Discuss indications for use, and discuss sputum indication or indication. Now, not only is this aerosol humidity, but this is also about chest physiotherapy. Okay, this whole unit is aerosol humidity and chest physiotherapy. Okay, we're talking about getting those secretions up. Okay, whether we can loosen them up, because if somebody has thick, tenacious secretions, right, or incipient secretions, they're just locked in, they just dry and thick, you know, like really, really like almost like bubble gum, sticky type, right? A regular patient or patient who's sickly can't, if they don't have a really strong, productive cough, then they can't cough it up, okay? Any kind of secretions or mucus that's left into the lungs is not coughed up will cause infection, right? It'll cause it to become pneumonia, cause you not to be able to breathe well because the alveoli are full of mucus, right? You have to be able to get that stuff up. And so in this lesson, you guys are going to learn how we can do this with humidity. And if that doesn't work, how can we position the body to drain those segments, right? Or beat on the body, which is called percussion, to help loosen those secretions to make you be able to cough them out. This is where your segments come into play, knowing the segments of this lobe, knowing the segments of that lobe. Because if the doctor says you have locked in secretions or very tenacious secretions in the apical segments of the left or right upper lobe, right? Or in the apices of the lungs, you got to know how to position your patient in order for that to drain out, okay? We want these secretions to be able to drain out, okay? So the best way to do it is to get that segment up in the air, okay? So for instance, the superior segment of the left and right lower lobes is where? The superior segment of the left and right lower lobes, right? Where are they located? Where is it located? In the back. The superior segments are in the back, okay? Both of the left lung and the right lung have a left and right lower lobe. The segments of the right lower lobe and the segments of the left lower lobe both share a segment called the superior segment, and they're both in the back. All right? So how would you place your patient to drain that from the back? What's the term? Prone. You got to lay them on his stomach so that it can drain from the back. All right? So, for instance, this is a lung, right? Okay? This is a lung. The superior segment of the lung will be in the back of the lung, okay? So you have to have them laying down so that that segment can drain toward the middle, because all of the larger airway is where you want it to get to, right? The left and right main stem bronchus. If I can get it to there, then I can cough it out. But if it's in the segment, you can't feel it. You don't know it. You can't cough it out. You can't do anything. You have to. It has to come out to the larger airways. When it gets to the larger airways, that gives your body a tingling sensation to cough. All right? You don't feel a tingle when it's way in your segments. You can't feel that. Let me cough this out my left lower lobe right quick. You can't do that. Okay? It's only when it gets to the larger airways that you can feel it and the body tries to expel it. Okay? Also, make sure you're in your book and reading your Egan's book, because there's some good information about cough and how cough is initiated and where are the segments, where are the secretions when that cough is initiated. Okay, that's very important. All right, but anyway, so you want to get that segment, whatever segment is infected, you want to get it up in the air so it can drain. That's the bottom line. Okay, so it's like playing those games you used to have a long time ago. You remember there's a little, you can buy them at, sometimes you play them at baby showers, little gag games where they have this little ball, this little metal ball that's in the maze, right? And you have to try to turn it where it goes into this way, and you know what I'm talking about? And that's what you're doing with the segment. Whatever segment's infected, you're trying to get that ball to drain out. Turn it to where you can get it to drain out, wherever it may be. All right. So if it's in my apices, if I have secretions up in my apices, I want the patient sitting up. Right. I don't want his head down. Right. I want him sitting up so he can this a drain down. Okay. If they're in my lateral segments, I want them to be on the opposite side. So if my left lung is affected, just say I want to drain my left lung, right? Well, I mean to lay them on their what? On the right. Lay them on the right so that the left lung is up in the air and it can drain toward the middle, okay? Now, that's the drainage. Not only do we do drainage, but while he's laying on his side, we can do what's called percussion, where we, right, we're beating on a certain segment. How your hands are cupped, it must not slapping, but a cupped sound where you're, right, and you turn them wherever they need to go, and you beat on that segment, and that will help shake and vibrate that stuff out to come out to the larger airways, okay? That's what you would do physically. We also have devices that we can use. I can give you a PEP device. I can give you a flutter device where you blow into it. The flutter device, you would blow into it and it shakes like that. There's a little flutter inside that shakes, gives you a little back pressure in the lungs to help shake, and help you cough that stuff up, right? The PEP therapy or the PEP valve is PEP, is a little valve you blow into that gives you back pressure. It doesn't float or fly or vibrate, but it just gives you back pressure, which helps get air behind them secretions in the alveolar. So you're gonna learn all about this stuff in this section. So this is a large section, okay? This is a large section, not only just humidity and aerosol, but also bronchial hygiene. That's what we call it. Bronchial hygiene is getting that stuff up out your lungs, okay? All right, let's get into it. Humidity. What is humidity? Humidity is water in a gaseous state, also known as water vapor, also known as molecular water in a gas. All three of those are humidity. Please remember, humidity you cannot see. Okay, humidity you cannot see. Aerosol you can see. All right, aerosol you can see, humidity you cannot see. All right, so right now we're talking about humidity. Then we're going to talk about aerosol and how they're alike and then how they're similar. I mean, are different. Okay, there's some reasons how they're alike and there's some that reasons why they're different, how they differ. Okay, they're not the same. All right, so let's talk about potential humidity, which I just taught you. Potential humidity is the amount of water vapor that a gas can hold. All right, that's how much it can hold. But that don't mean it's holding that. All right. Just like if I know that you are capable of making 100% on a test, right? But that don't mean you're gonna make it, right? That doesn't mean you're gonna make it. Just mean you have the potential. If you make a 50 on the test, then you are only 50% of your potential. If you make 80% on it, or 80% on the test, you were 80% of your potential, right? If you only make a 20 on it, then you only did 20% of your potential, okay? All right. The potential humidity is determined by the temperature of the gas. All right. Number 3, sometimes referred to as what? Capacity. All right. Now, saturated. What does it mean when it's saturated? Saturated means when the gas has reached its potential at that temperature. Okay, because when the temperature changes, the potential changes. Okay. Now, when the gas has reached its potential at that given temperature, it's considered to be saturated. Okay, that's when it's considered to be saturated. So for instance, at 37 degrees Celsius, alveolar gas has the potential to hold 44 milligrams of water, and it holds it. Okay, it's also holding that 44, so it's 100% saturated. right? Also known as 100% relative humidity, okay? It's saturated. Now, if the temperature of the body changes, then that stuff changes, okay? Temperature determines the potential, all right? Absolute humidity. Absolute humidity is water, amount of water held in the gas. So what you got, okay? Just look at that as what you got. All right, so make sure you write that down. Oh, you understand it. The amount of water held in the gas at any particular time is its absolute, right? It's what it has right now. And it's expressed in milligrams per liter, okay? Milligrams per liter. So let's get to relative humidity. Relative humidity is absolute humidity over potential humidity times 100, and it's written as a percent. Absolute over potential times 100, okay? So Ms. Rose, if you have the potential to hold 100 milligrams of water, but you're only holding 50, what percent are you holding? 50%. That's what this relative humidity is, okay? And always gonna be that cut and dry, okay? Maybe you can do some, calculating, and won't be no problem. But like it might be supposed to hold 44, that's only holding 12, right? Then you just have to do the math, okay? It's not always 50% or 100%. All right, alveolar gas. I just told you about that too. Alveolar gas is 100% relative humidity, right? At 37 degrees Celsius, alveolar gas holds 44 milligrams per liter of water. At 37 degrees Celsius and 100% relative humidity, the pressure exerted by that water vapor is 47 millimeters of mercury. That's where we get the 47 millimeters of mercury from in the alveolar air equation. Everybody understand that part? All right. Humidity deficit. Now, sometimes there's a deficit. It's the amount of humidity in alveolar gas minus the amount of humidity that you inspire. Just because you have 44 milligrams of water in your lungs don't mean it's 44 outside. Okay, it could be something else. If it's lower outside, you just subtract. That's the deficit. So if I go somewhere and it's really, really dry, right, like Texas or Arizona or something like that, I'm going to have a really high humidity deficit, okay, because my body has to have 44 milligrams of water for each breath, right? So if I go somewhere where it's really, really dry climate, then the humidity outside is very low, okay? And so I have to subtract my 44 from whatever's out there, and that's my deficit, okay? My body has to make up that deficit of being out in the dry air, okay? Because they say just because you're in California don't mean you can just give me any kind of humidity, okay? I need 44. So the body nose is gonna have to work extra in order to produce that, what you need, okay? Now, humidity supplied to inspired gas by the nasopharyngeal and oropharyngeal passages, the nose in the back of the throat, right? That's what gives you your humidity and your temperature, right? That's what gives it, the magical nose, right? The magical nose is what gives us that humidity and that heat. If it's not supplied by the nose, then the moisture has to come from somewhere, okay? It's got to come from somewhere because the lungs demand it. So if it doesn't come from the nose, where's it going to take it from? Thank you. Which dries and thickens the secretions. Now my secretions are getting thick and dry because my nose is not doing his job. So now the air is taking the moisture from the mucus blanket, right? Don't forget the mucus blanket is that blanket that's in your larger airways, right? It's moist, but if the nose doesn't heat up and moisten up that air, by the time it gets to the trachea, it's going to start taking moisture from the trachea and the mucus blanket. And that's going to make the mucus become more and more what? Thick and dry. And if it's thick and dry, it can't move. And if it don't move, it's going to start to be retained. And if it starts to be retained, it's going to start setting up infection, right? It's a domino effect, okay? It's a domino effect. Now, so let's talk about that. Let's talk about what inadequate humidification can cause. Inadequate humidification can cause decreased cilia activity, right? Because the cilia is what move the mucus blanket. If you don't have the humidification, now that mucus blanket is becoming thick and dry. So now the cilia can't move it, right? Number two, decreased movement of mucus, right? Inflammation and necrosis of pulmonary epithelium. Now you start to inflame the pulmonary skin tissue and they start to die, okay? Retain secretions. Bacterial culture media, that means you're starting to set up infection. It can cause atelectasis, which is little pockets of alveoli that close, and pneumonia. All of that is a domino effect just by not having the adequate amount of humidity. And a lot of your patients, guys, are going to have a artificial airway, okay? Either ET tube or a trachea, okay? And so you got to make sure that they're not just sucking in this dry outside air because it's bypassing the nose. So now it's not being moistened. It's going straight to the trachea, drying out the trachea and the mucosa, okay? All right, so it's 3 more minutes, we'll take a break. So what are the indications for humidification? The indications for humidification are to prevent dry gas from drying the mucosa. That's number one. To prevent the dry, because we said oxygen is very, very what? Dry. Medical oxygen or medical air is very, very dry. No, there's no moisture in that cylinder, okay? All right, number two, to provide near body humidity when upper airway function is impaired or bypassed. So if somebody has a car wreck and has a face crushed, they're not breathing through their nose no more, not breathing through his mouth no more. His jaws have been wired shut, crushed jaw, crushed nose, all of that, right? From a high impact car crash, not wearing a seatbelt. All right, so we have to cut a trachea, emergency trachea, to breathe for the patient. Okay, can't intubate because all this is all crushed up. All right, so you have to cut a hole in the trach, which is a tracheostomy, right, or otomy, and put in a tracheostomy. Okay, and breathe for them. But now the nose is bypassed, so I got to provide aerosol to the line so that the moisture can get in the airway. Some hospitals also heat that humidity. Right? Remember I told you some of them heat, some of them don't. You should always heat and humidify any kind of gas that's bypassed the nose. But some hospitals won't do that. So when you get out there in clinicals, you don't go to the manager saying, you're supposed to be heating this, right? They know that. They know that. But like they said, there's a catch-22 because as you heat more gas, you have more potential for bacteria, okay? And so that breeds more bacteria. And so they try to take the risk, but I heat it up or do I risk introducing infection? Okay, so just some hospitals do, some hospitals don't. All right. So those are the two main indications for humidification: to prevent dry gas from drying you out and to provide near body humidity when upper airway function is impaired or bypassed. What's body humidity? What should it be? Body humidity, what should it be?
100%.
Saturated, yeah, but what should the amount be? 47 pressure, what's the amount? 44. 44 milligrams per liter of water vapor should be in the body, okay? The nose does that job. That's body humidity, okay? Body humidity should be 44 milligrams of water at 37 degrees Celsius because normal body temperature is 37 degrees Celsius. So at 37 degrees Celsius, the body can perform and provide 100% relative humidity because at 37 degrees Celsius, the water has the ability to hold 44 milligrams of water. And it does that in the alveoli. So it's 100% relative humidity, also known as 100% saturated. That's body humidity. And so since we're not doing that because he's bypassed the nose, now you and I as therapists have to provide 44 milligrams of water per liter. That's what you're trying to do. And you're trying to heat it up to about 37 degrees Celsius. That's what you're trying to do as a therapist when that airway is bypassed. Okay, so we have to give that near body humidity when the upper airway function is impaired or bypassed. All right, so I'm gonna pause the recording here. It's 10 o'clock. Come back at 10:10. All right, so clinical application, guys. Let's break this over. Clinical application of this relative humidity and what it's doing. This is something very, very important to understand so you can see what I mean with the words. If a humidifier, and now we're talking about the actual humidifier, right? If a humidifier has or puts out a relative humidity of 100% at any given temperature, is what they're saying, and the temperature of that gas then increases, the relative humidity will decrease. Okay, so let's see why is that. Look on the board. At 70 degrees, I want y'all to tell me what happens. At 70 degrees Fahrenheit, a gas has potential to hold 50 milligrams per liter of water. If the temperature increased to 80 degrees, now the potential has gone up to 70 milligrams per liter of water. If the absolute humidity is 50 of that gas, then what happened to the relative humidity when the temperature increased? Huh? Say it again. It decreased. It decreased. Let me show you why. Now, let's look at the first one. At 70 degrees Fahrenheit, gas has the potential to hold 50 milligrams of water, right? So let's say at 70 degrees, Fahrenheit, I said the potential was 50 milligrams of water, right? And the absolute humidity is what? 50 milligrams of water. So what is this relative humidity? 100%. Okay? Now, but the temperature increased to 80 degrees Fahrenheit. Now look at it. The potential is now what? Yes. At 80 degrees, the potential went up to 70 degrees, right? So 70 milligrams, right? Now, but the absolute humidity is still what? 50. So what's the relative humidity now? How much? 71? So about 70%. See how the humidity went down? It's just simple math. Okay? The potential at 70 degrees is 50 milligrams of water. That's what I just said, right? The absolute humidity is 50. That's what it actually is holding at that moment, okay? But then for something happened, the temperature went up. The temperature went up to 80 degrees. Well, we know that at 80 degrees, it now has the potential to hold 70, right? But it's still only holding what? 50. So the relative humidity has decreased. The temperature went up, the relative humidity will decrease.
Is that normal?
Yes, that's what happens. Because the potential went up, but that gas at that moment was only holding 50 milligrams of water. And while it was at 70 degrees, it was holding what it was supposed to be holding. It could only have the potential to hold 50, and it was holding 50, right? But the temperature rose up on them, right? So when the temperature increases all of a sudden to 80 degrees, well, and I'm just making up this, that don't mean every time it's 80, it's 70, okay? These are just numbers I'm using, okay? But the process is the temperature goes up, the potential goes up, okay? The potential to hold more goes up. But the absolute humidity, I'm telling you, is still 50, right? And so at 70 degrees, we had a relative humidity of 100%. And when the temperature went up to 80, the temp went up to 80, the potential went up as well. But the absolute humidity was still 50. So the relative humidity goes down, okay? So as the temperature increases, the relative humidity will decrease. And that's why. You don't understand that? Okay? You weren't here when we did relative humidity, right?
No.
Okay, well, that's the formula. Relative humidity equals absolute over potential times 100, and it's written as a percent. Y'all get it? Understand? Okay.
What does that indicate, like when you, like with a patient?
Huh?
What does it like indicate, like when you do this?
It's just talking about how saturated that gas is. Whether the gas is 100% saturated like he should be, or is he only doing a little bit of what he should be. Okay? And that's going to tell us because if our relative humidity in the body is less than 100%, then we're going to start drying out. Okay, we're going to start drying out. So we need to know how to find relative humidity, which is the same thing they do outside. The meteorologist is going to tell you what the relative humidity is at any given temperature. That's why they say temperature today is whatever, right? 65 degrees has a relative humidity of such and such and such, right? Has the potential to hold this, but today we're only going to really be holding this, so our relative humidity is that, okay? If I tell you that you have the potential to hold $100, but I check your pockets and you're only holding 50, you're holding 50% of what you should be holding, right? Okay, so that's how you find it. So absolute is what you got. What the amount of water held in a gas at that moment is absolute humidity. That's absolute, right? Now, whether he's doing what he should be doing is another story, okay? Potential is what he should be able to hold, okay? So at 70 degrees, I'm telling you that a gas has the potential, which should be able to hold 50 milligrams of water, okay? And it's holding 50 milligrams of water at that temperature. So that's 100% relative humidity, 50 over 50. 1 times 100, 100%, okay? But somebody cut the heat up. They cut it up. So now the temperature increased to 80 degrees Fahrenheit. Now at 80 degrees, it has the potential to hold 70, okay, milligrams of water. But it's only holding how much? 50, because the absolute is what you got, and it's 50. So 50 divided by 70 times 100 gives me 70%. So relative humidity went down. So as temperature goes up, temp increases, relative humidity will decrease. And that's why, okay? Because as the temperature go up, it's got the potential to hold more, right? But that don't mean, this is it right here. You have the potential to hold $100, right? Because let's say you got 2 pockets and I got money in both pockets. So you got the, if I stuff both your pockets, you have the ability to hold $100, okay? And if I check your pockets, you hold $100, then hey, you're 100% relative humidity, right? But what if you take that money and put it on the table and change pants to a pants that's got 20 pockets, right? Now you have the potential to hold more money, right? But you only got $50. I mean, $100. You put that same $100 you put on the table back into your couple of pockets, right? But you got 20 pockets now. That don't mean you got money in all of them, right? So your relative humidity went down, even though your money stayed the same, okay? You had 2 pockets and had, let's say, a $100 bill in both pockets, right? So that's $200, right? I said you got the ability to hold $200 in them 2 pockets. And I check your pockets, you got $200. But if you take that money and put it on the table, and then I give you some more pants, some bigger pants, right, that have 20 pockets on them. You take them same $200 and put them in your pockets, you're not holding what you should be holding, right? If you can hold 100 in each pocket, you should have $2,000 now, right? But you don't, okay? That's how that works. So as the temperature goes up, the relative humidity goes down, okay? And let's look at this one.
So this isn't on the specific pages, we're just talking about types of gas.
I'm talking about relative humidity right now. This is not talking about a specific patient. It's talking about the science behind temperature and water.
So it's always supposed to equal 100.
Relative humidity don't always equal 100%. Just whatever it equals, that's what it is.
Okay.
But alveolar gas should always be 100%. Because at 37 degrees Celsius, the body has the ability to hold 44 milligrams of water. And when I check your alveoli, it's going to be holding 44 milligrams of it, it can manage it. So the relative humidity is 100%. The gas in your lungs has 100% relative humidity. It means it's 100% saturated. Okay? But it's important because when you get a temperature, right, get a fever, now you're above 37, right? So your relative humidity in your lungs is not going to go down because the temperature went up. So you had the ability to hold more, but you're only holding 44. So the relative humidity is going to go down. Okay? That's why it's important. Temperature, temperature, temperature. All right, and the other aspect is this. If the temperature decreases, relative humidity stays the same. As the temperature decreases, the relative humidity will stay the same. And I'll show you why. All right. Let's say at 80 degrees Fahrenheit, a gas has potential to hold 100 milligrams of water. Okay? Absolute humidity is 100 milligrams of water. Okay? That's one situation. Now, the temperature decreased to 30 degrees Fahrenheit and now has potential to hold 40 milligrams per liter. And since the temperature dropped, the absolute humidity also drops. So absolute humidity is now 40 milligrams of water. And the reason why it does this when it goes down is because of rain out. So let's look at it. What is the potential right here? I mean, what is the relative humidity of this right here? 100%, because we say we have the potential to hold 100, and it's holding what? 100. So the relative humidity is 100%, right? Well, the temperature drops. If the temperature drops, the potential drops to what? 40, and the absolute also drops to what? What's the relative humidity? 100%. Still 100%. Stays the same. It stays the same because both the potential and the absolute will drop when the temperature drops. Okay? Because of rainout. Because as it gets colder, those water particles get heavier and they drop. They can't stay suspended. Right? When they're warm, they can stay suspended, floating in the air. But if I cool it off, they start to come together. They get heavier and they rain out. So the absolute now is not there. The absolute dropped because it was in the air, but now it dropped. It's gone. It rained out like rain. Okay? The temperatures in the clouds. The clouds have water vapor. That's all clouds are we see every day. That's just puffs of water vapor.
That's why that's the reason why I'm confused. I'm like, I thought it would do that in heat. Because that's what the evaporation happens and stuff in the heat.
Evaporation causes that water that's already rained out because the potential goes up. As the temperature gets hotter, it has a potential. The air has more potential to hold gas, right? Because it's turning that water into a gas. So now you have more potential. All right. But what happens is, as those puffs of clouds are floating, as they get colder, those water particles, the absolute humidity in the cloud starts to coalesce. They come together, they start turning gray. The reason why you see them gray is because they're getting bigger. The water particles are becoming together. And they get so heavy to a certain point where they like, ah, and they just fall out the sky, okay? The absolute, which is the amount, right, drops out of that gas, okay? It drops out of the gas and turns into water particles. So now the gas itself has a lower absolute because it's no longer floating, it's dropped out, all right? So just remember, as the temperature goes up, the relative humidity will go down. If the temperature drops, the relative humidity does what? Stays the same, because both the potential and the absolute will go down when the temperature goes down. Okay? They both gonna go down. For instance, this tubing right here, if I have aerosol going through this tubing, if I have, it's warm from here to here, it's nice and warm, like I got something, a heater on it or something that's nice and warm, it'll stay nice and smooth, right? It'll float. But on this side, I have this refrigerated, right? I got this going through a refrigerator or something. The water inside of here now is going to be drops of water. By the time we get on this end, it's going to be dripping out the end, okay? It's going to be floating through this side, but by the time it gets to the coldness, it's going to start, the temperature is going to start making the temperature inside of here drop, right? And so the potential goes down and the absolute will go down. It starts to rain out. So down the water, instead of misting out, it's going to be dripping out on this end because the temperature went down, okay? All right. So for instance, this is what rain out looks like. I have a tube, a large bore tube, all right?
When it's cold, they get wet, and then when you turn the defrost on, which is warm, it dries up. I don't know.
All right, so look right here. This is the large bore tubing, okay? Large bore tubing. Let's just say on this end, 37 degrees Celsius, right? From here to about here, okay? Well, the water particles we have will be nice and suspended, right? Water vapor. All right, nice suspended aerosol, or just to say humidity, right? It's just nice and suspended air, suspended on air, right? Well, something happens in the patient's room. You know how they like to have the air on and all of that, right? So by the time that line gets to the patient, the temperature might be different because the machine is what's giving the heat, right? We have a little heater on the machine and it gives a little heat, but by the time it makes it to the patient, grandma could have a room on 50, right? The air conditioner on 50 in the room. And so let's just say on this side, the temperature is now 10 degrees Celsius from here to here, right? The temperature has decreased, right? So now these water particles now are getting bigger. Oh, this is a bad marker. These particles are getting bigger and they start to coalesce. What's coalesce mean? Collect, come together, right? Start touching, and now the water starts to come down, called rain out. So now we have, right? This all be what? Water. It's falling down. It's too heavy. It can't stay suspended. That's what's happening. Over here, you have great potential for to hold that water, right? That gas can hold it. But as the temperature go down, the gas is trying to hold the water, and the water getting too big for its hands, right? So as you're walking and you're getting the temperatures going down, the water in the gas is getting too heavy for the gas to hold. And so it's just got to let it go, right? It's too big. I got to let it go. The particles become bigger and bigger. They start to coalesce, and that's called rain out. This is called rain out. Just like rain, right? As the temperature drops in the sky, those water particles that's in the clouds become bigger. They start to get bigger, and they start coming together. And they get heavier and heavier to the point where they can no longer stay suspended, and they fall, right? So when it falls, the water now has left the gas, right? So if the water leaves the gas, that means the absolute potential, absolute humidity of the gas has gone down because the water is gone. Because absolute means the water vapor that's in a gas at that moment. That's what absolute is. Absolute humidity is the amount of water in a gas at that moment. Well, if the water leaves the gas and drops, now the absolute has gone down because it's gone, all right? So when the temperature goes down, they both go down, which makes the relative humidity stay the same, okay? Don't make it harder than it is. Don't overthink it. It's simply what I just said. Temperature goes up, relative humidity goes down because of those things, right? If the temperature goes down, the relative humidity stays the same because they both, absolute and potential, both go down. If you do the math, it's 100%, okay? Just do the math. Okay. Easy to see. I'm trying to, for the recording. One side is 37 degrees. Once it gets to the 10 degrees, temperature goes down, those particles get bigger, and they start to come down and fall out like rain, okay? So that's why we have to have a water trap in our aerosol setups, right? Because it's going to get cooled off, and they're going to start collecting together and fall down, right? That's what's happening. That's why we have, if that didn't happen, we wouldn't need a water trap. We would not need a water bag in our circuit, right? Why have a water bag if that's not going to be a problem, right? Because rain out, because the temperature changes from device to the patient, because especially when they have a heated device, right? Some hospitals have it heated. So this bottle of aerosol, whatever, aerosol trait color, aerosol T-piece, whatever it is, this bottle may have a heater on the bottom plugged up to the wall. So all this is nice and hot. So you have hot, nice 37 degrees temperature going through your bottle, through your tubing, right? The gas, but when it gets way down to the patient, the room is cooler than the bottle. So as the room starts cooling on the circuit, the water inside the gas inside gets cooler. The temperature goes down. Now, since it goes down, it's kind of like the hands of the gas get smaller. It can't hold the gas no more, so it starts to drop out, and it'll start to collect, okay? And so you have to have a bag there to collect that water, or you're going to let that water get down in your patient's airway. All right? All right, so this is what I just said in a nutshell. Example, if at 30 degrees Celsius, a cascade puts out 100% relative humidity, and the temperature increases to 37, less than 100% relative humidity is delivered to the patient, right? Because the potential went up, but the absolute stayed the same. So that made the relative humidity percentage go down. Number two, if the temperature of a gas that has a relative humidity of 100% decreases, the relative humidity will stay the same, but the potential and actual humidity will decrease, which result in rain out and a decreased delivered humidity. Okay? So if the temperature goes down, those water particles can no longer stay suspended. You're going to have rain out. The absolute going to go down. The potential is going to go down, and it's going to rain out like rain. Okay? All right. So an example, a humidifier puts out a gas that is at 37 degrees Celsius and has a relative humidity of 100%. Okay? So that what they're saying is a humidifier that you got using, a heated humidifier to give to the patient. It puts out a gas that's 37 degrees Celsius and has a relative humidity of what? 100%. All right. The gas that is delivered to the patient through the large bore tubing. Okay. As the gas travels through the tubing, it is cooled because the average room temperature is about 24 degrees Celsius. This causes the delivered humidity to drop from 44 down to 22 and causes the water vapor to rain out and form condensation. So that's the words of what I just said on the board. Okay, the temperature goes down, the potential and the absolute both go down. So now the percentage is less, right? The potential and absolute go down. So you still have 100% relative humidity, but the absolute you're getting is less. You're supposed to get 44, but now you're only getting 22 because the potential is only 22. Okay, so the relative humidity stays the same percentage, but the amount that you got is less because of the lower temperature. Okay. All right. Aerosol. Aerosol is a little bit different. Aerosol is the water particles that's suspended in the air that you can see. All right, you can see them. All right, so the example I was using to try to show you what relative humidity is through this tube would more be like the aerosol that you see. All right, I had to use that so you can understand what I meant by humidity and the temperature going down and rain out and all that. Okay, but the same thing happens with aerosol. If that tubing gets too cold, that aerosol is going to drop out and be like rain. All right, so what are the differences between aerosol and humidity? There's a couple of main differences that you need to know for the exam and for your therapy, period, as a therapist. Aerosol is water particles suspended in air, okay? Humidity is water vapor in air, okay? Water particles that you can see, right? Aerosol you can see, humidity you cannot see. Aerosol you can see, humidity you cannot see. It's also known as particulate water in a gas, also known as a mist, also known as fog, okay? You can see, can't you see mist? You can see fog, right? Aerosol you can see, humidity you cannot see. Like this room right now has some humidity in it, okay? It's gonna be some type of humidity in the room right now, but you can't see it, all right? But if I turn on one of these aerosol tray collar, aerosol teepees or whatever, it's going to mist and you're going to see it. That's aerosol, okay? That's aerosol. E, the stability. Now, what's the stability of an aerosol? The stability is like a magical thing. Stability of an aerosol is the ability of the particles to remain stable, suspended in gas. So long as you see it floating, it's stable, okay? It's stable. But there's some factors that affect that stability. There are some factors that affect the stability, okay? What's the first factor? Concentration, which is the number of particles. A should be number of particles. And the more particles they have, the more they bump together. Now what happens because of Laplace? Laplace says when water particles bump together, they do what? They combine, right? We learned about Laplace. As those water particles are floating in the air, they start touching each other, and the larger one's going to suck in the smaller one, right? So they're going to combine, right? They're going to combine. As they keep combining, they get what? Bigger and heavier. And to some point, they won't be able to float anymore. They get so heavy that gravity is going to just pull them down, okay? They become more dense, whatever you want to say. The gravity will then pull them down. So now they're no longer stable, right? You got that particles that are floating nice and small sizes, right? They're just floating. You can see them. They're doing the job. But because of Laplace, we said they start to come together because of physics. As they get more particles together, they bump together and they start getting bigger. And then look at number 2, it says size. The larger particles are too heavy to float and they rain out. Okay? Relative humidity also affects the stability of aerosol. A low relative humidity of the gas causes particles to evaporate. If it has a low relative humidity, it causes the particles to evaporate. Okay? Penetration and deposition. Now, the reason why we're speaking about this is because when we take a breathing treatment, how is it given? It's by mouth, but I'm saying, what's the mode of, the mode is inhalation, right? Because what are we inhaling when we do it? What is it? The aerosol, right? It's an aerosol treatment, okay? It's an aerosol treatment. It's not a humidity treatment. It's an aerosol treatment. So when you have your little small volume, you've seen a breathing treatment before, right? So when you give somebody a breathing treatment, it's the smoke coming out of there, right? That's aerosol, okay? So that's one of the major differences between aerosol and humidity. Aerosol can deliver what? Medication. Humidity doesn't. Aerosol can deliver medication. So what happens is the medicine rides on those water particles. And that's how they get into your body, okay? Now, penetration and deposition are two very, very important words. Where does the medicine have to get to in order to be functional? Where are we trying to get that medicine? Just in the back of the throat? Alveoli. We're trying to get them to the alveoli so it can get into the bloodstream, right? Because the gas exchange and the blood exchange, all that's in the alveoli, right? So if we're breathing a breathing treatment, we want that breathing treatment to get all the way down to the parenchyma, right? Which are small airways, right? And so that's why penetration and deposition are two very important components of this. Penetration is the depth at which the tracheobronchial tree that the particle can reach. How far can that particle get? That's its penetration ability, okay? And then deposition is where does it ultimately land, all right? Deposition is particles rain out in a particular area. So where does it actually fall out? Where does it end up? That's its deposition. And so we want medicine to get as far and deep as possible and deposit where? Into the alveoli. That's what we want, okay? So there's a certain amount of size that can do this. You're gonna learn what the therapeutic size of particles are, all right? There's a certain size of particles that will deliver this. If we have huge particles, they're gonna deposit in the back of the mouth, right? If I'm, like if you splash in water, like if you take some splashes of water, like water, if I spray from a sprayer or something, that's large particles. That's not gonna get all the way down into your alveoli. That's not stable, right? If the particle is too small, guys, it will go all the way to the parenchyma and come back out when you exhale and never deposit if it's too small, okay? If it's too small. So there's a size range for this, okay? For it to get way down to the parenchyma and land there. That's what we want, all right? So that's what I want you to have that in your mind as we talk about penetration and deposition. Penetration is the depth of the tracheobronchial tree that the particle can reach, all right? And deposition is particles rain out in a particular area. So that's where the particles land. That's the deposition, okay? If they're really, really big, they're going to deposit in the back of the throat, okay? If they're really, really big, they may deposit on the tongue, or some of them might get to the trachea, but that's about it. They're going to hit the trachea, land, and that's it. Never gets to the parenchyma, all right? If they're super, super duper small, they go all the way down to the alveoli, but never deposit. They come back out when you exhale, right? So that's wasted. It just it was too small, okay? And this is why we have to wear a mask, a certain type of mask when somebody has the flu or anything like that when you're giving them a breathing treatment. Because not only does the medicine come back out, but what else comes back out and rides on that particle? That virus will also jump on that particle and come right back out, okay? So you inhaled a really small particle, the virus jumps on that particle and then blow it right back out in your face, okay? So you have to have a special mask when they have something like that, like flu or coronavirus, of course, but flu was before this came out, it was flu. They had a certain flu or something like that, you needed to wear a mask. Or if they had AIDS, we give a special kind of medicine for AIDS patients. You have to wear a mask because that AIDS particle jumps onto that small particle that's going to be inhaled back out or exhaled back out. Okay, so that's why we want a certain size. Not too big, not too small. All right. All right. What are the factors that you think influence penetration and deposition? Number one is what? Gravity. Gravity. The larger the particle, the more likely it's going to drop or rain out before it gets to the alveoli. What's number 2? Kinetic motion. Now this is saying that the particles, the more they move, the more likely they're to bump together, coalesce, and rain out. Okay, so kind of like your airways, they turn corners, right? The left and right main stem bronchus, then they have to branch off to the bronchi and the segmental bronchi, bronchioles, all that turning that it's doing. That's kinetic motion. As those aerosols are turning corners and stuff in your tracheobronchial tree, some of them can hit some of the corner and rain out. Right? They turn in corners and they start bumping together more. All right. So you have to take that into consideration. Inertial impaction. Inertial impaction is the next one. Inertial impaction. When the airways narrow and alter direction. So this is also when they turn in corners. Okay. When they get smaller and smaller, right? Because, you know, the trachea is a lot bigger than the terminal bronchioles and the respiratory bronchioles, right? So as those airways get smaller and smaller and smaller, it starts hitting against the wall. If it's turning the corner, it can hit up against the wall, right? If you're running and you're trying to turn corners of a building, right? You can't hug that corner perfectly if you're running, right? And so you're going to have to slow down a little bit so you can hug that corner if you're going to make a left. But if not, that the gas that's going past that corner, some of it hits against the wall. Okay, that's all it's saying. That's all. If you have a car wreck, your body keeps doing what? Moving forward. Okay, the car gonna stop, but your body keeps going forward because of inertial impaction. Inertia. Okay, so inertial impaction is just saying as the airways get smaller and more narrow, and they start to turn corners, the aerosol particle may continue on the same path and deposit by bumping into the airway wall. Okay, so all they're saying is this: if you have right, as the airway, the airway particles are going in this way, sucking it in, right? Well, they have to turn corners, right? Some of them will turn corners, but some of them may bump up against this wall, right? You're gonna have a little bit of collection right here. Now, you know, the rest of them will keep going, but as it turns the corner, some of them may bump against that wall right there because it turned, right? It kept going, that force of going straight. When it turned that corner, it still kept going because of inertia, okay? Because of inertia. That's, you know, not nothing big.
So it's saying that the particles that do hit that corner are not going to make it to where they need to be. Like,
Yeah, if they hit some of them, they hit the wall because of inertial impaction. They're gonna be, that's where they deposit. That's the end of the road for them. Okay, the rest of them keep going. Okay, that's why we want them to be a certain size, because we know that some of them are going to hit. There's no way for all of that to not touch nothing. Okay, especially your what, depending on your what, ventilatory pattern. If I'm taking in a breathing treatment and I say, is it gonna get to my parenchyma? It's gonna all slam into the back of my what? My throat, right? It's not gonna make it, right? Like, hold on, Mr. Johnson, just slow down. You know, relax. He's trying to get the track. He's trying to get. Yeah, he's doing all that. He's good, right? But if you have a ventilatory pattern like that, it's not going to make it. It's going to slam into the back of your throat, right? But a slow, deep inspiration with the inspiratory hold. That is you need to write that down. Slow, deep breath with an inspiratory hold. That is the best therapeutic breathing pattern for aerosol treatment. Slow and deep with an inspiratory hold. Slow and deep with an inspiratory hold. If we do a slow and deep, we can get that gas. We'll just go laminar. It remains laminar, and it goes in, turns the corners, and gets all the way down to the parenchyma, and we hold it. Hold for 3 to 5 seconds so it can go ahead and deposit. Then we exhale. Okay? Slow and deep with an inspiratory hold is the best breathing pattern for aerosol deposition. Okay? Slow and deep with an inspiratory hold. So inertial impaction, depending on how I'm breathing, matters big time of how far it penetrates and where it deposits. Here it is right here, part G. Penetration and deposition continue. D says ventilatory pattern. Ventilatory pattern matters. How it looks. I mean, how far it goes, depending on how you breathe. Alterable factor influencing deposition and retention. They're just saying it's altering because if you change the pattern, it's going to change how it deposits or goes. You got a problem? The last one was this right here. You don't have this part here? The ventilatory pattern? Oh, don't worry about it. It's just probably just on my thing. It's letting me know I'm continuing on aerosol. Huh? You see D for aerosol? I mean, ventilatory pattern? It's just letting you know what I'm saying. You see D. For that's all you need here. You just continuing on with these last lists, A, B, and C. A was gravity, B was kinetic motion, C, inertial impaction, and D is ventilatory pattern. Okay? This G and this H is pretty much on my lesson plan, letting me know that the page is continuing. Okay? All right. The ideal pattern is a slow, deep breath with a what? Inspiratory hold. Slow, deep breath with an inspiratory hold. All right. Let me see how much is left. All right, we're going to finish up this, and then we're going to be done for the day. Clearance. Clearance is H. Clearance. Clearing our airway. Aerosol adds water, liquid water, to the lung, right? If I'm breathing this aerosol, it's going somewhere, right? It's depositing, and it's starting to add to my water intake, okay? So I have to be careful with my water intake, because if somebody who already has water retention problems, like pulmonary edema, if somebody already has a lot of fluid in their lungs, don't give them a whole lot of this, right? Because look at this. Over one shift of a shift, all of this bottle will be gone in one shift. I would have to change this bottle every shift. And this shift, this water is, let me see, how much is it? How much does it say it is? How many mLs of water? 1,000. See that 1,000? Sterile water for inhalation. You can't see it? Sterile water for inhalation, 1,000 mLs. So every shift, if a patient is on this, you are adding 1,000 milliliters of water to their body. Okay? And that has to be cleared. The body has to be able to clear that either through urination or coughing up, whatever. It's got to be able to clear it. All right? So you have to be careful, because if somebody has congestive heart failure, that's fluid on the heart. If they have pulmonary edema, which is fluid in the what? Lungs, you have to be mindful of that when you're giving them aerosol delivery, okay? Just be mindful of it, because you can give them too much and they start to drown, all right? You start to hear it in the, you can hear it kind of gargling and gurgling around in their body. You can hear it in the lungs, okay? So you have to be careful with the amount of water you give them, okay? So since aerosol adds liquid water to the lung, it must be cleared to avoid accumulation. Must be cleared. Now, how do we clear the water? Well, clearance methods right here. Mobilization of the mucus blanket, right? So as long as that mucus blanket is collecting that water and stuff like that, you're getting them, all those extra foreign particles up, you coughing them out. That's one way. The cough, right? Having a good cough. Lymphatic uptake. Your lymph nodes will soak up some of that water. Lymphatic uptake. Phagocytes. Some of your phagocytes will eat some of that liquid water. Okay, the phagocytes. And mechanical suctioning. If it comes too much and they can't cough it out, we have to go down and suction them out. Okay. Those are those cells that eat foreign bodies.
Like in the face.
Like, yeah. Phagocytes, macrophages, I think pretty much the same. All right, so those are clearance methods. Clearance soaked up by the mucus blanket to keep that nice and moist, right? We want that to be nice and moist. You can cough some of it up if you need to. Lymphatic uptake, phagocytes, and mechanical suctioning. That means I have to literally go in with a suction catheter and suction you, all right? If I hear that you got a patient that's sick, right, and they have a tracheostomy or something like that, they may not be able to cough well, okay? Yeah. Right? But you can hear it rattling in there. You have to go in and suction them. So patients with trachea, you'll suction them very often, right? At least 4 or 5 times a shift through the trachea. Yeah. And y'all learn suctioning more when you go to 220, okay? But suction is simply, there's a suction catheter, there's a sterile technique, it's in a sterile package. You have to don the gloves properly, have a dirty hand and a clean hand and all of that. Because it's still, you're putting something straight into the airway, so it has to be sterile as possible. And we stick the tubing suction catheter down through the trachea till we get to the carina, right? We feel it stop. That's the carina, right? Pull back just a little bit, put your thumb over the suction thing, and it'll suck all that stuff out. Okay, suction it. And you'll learn it in 220.
So, given this, like you said, a person with CHL, how do you monitor that?
You just monitor by the intake and output. There's an intake and an output part of the chart, right? Remember we talked about it in 210A. Talked about intake and output, right? There's a place where you go on the chart to look at that. If it becomes a problem, they can give the patient Lasix, right? A diuretic to help them pee more, okay? Because you can't not give it to them because they got CHF. You just have to know that you got a CHF patient, so we need to be making sure they're on diuretics, okay? Because we're adding to them. It can also start collecting in the skin. You can see they have edema, pedal edema, swelling on the arm. You can touch the finger and push down and water squirt out. Right? And that becomes when they're really sick. When a patient is really, really sick, their body and kidneys are no longer functioning, organs are shutting down, they start third spacing. The water has to go somewhere. If you're not peeing it out, if you're not on dialysis, it's got to come out somehow and start to come out the skin. You can push down a little puddle of water will be there. Because it's in the skin, it's in between the layers of the skin now. They're really, really sick, okay? Patients pretty much on their way out, all right? Now, so we're gonna talk about the indications and hazards, and then we're gonna stop. Tomorrow we will be on humidifiers and nebulizers, the actual devices that we use for humidifying and nebulizing. So I have some devices. We might go in the lab and do it tomorrow if he's not in there. Where I can show you some humidifiers and stuff like that as we teach it. All right? All right, so indications. Why do I give aerosol? Now, you already have some indications of why you do humidity, right? We said the indications for humidity was what? Indications for humidity, what were they? To dry them, keep the gas from drying the mucosa. Provide near-body humidity when the upper air is bypassed. What else? When we talked about humidity, it said the indications or reasons we give humidity. Okay. Okay, is that it? Okay. Now let's look at the indications for aerosol. Aerosol would be one, to thin secretions. When the secretions are so thick that, you know, they can't cough them up because they're so thick, now we need to give a little bit of aerosol to thin them out some. To thin secretions, number one. Number two, to improve cough. Now, when I say improve cough, I don't mean to make the cough louder. When I say improve cough, I mean get more up, okay? That's your job as a therapist. Yeah, give it to me, right? You want them to cough that stuff up, all over. Yes, that's what you want, right? You have to be that type of mentality, okay? Not because he coughs loud, because if he coughs loud, don't nothing come up, that's not a productive cough. I don't care how loud it is, okay? How strong it is. As long as it's productive, that's what we want. We want to see the yellow, thick stuff come up, right? That's what we want, okay? So a productive cough, when I say improve cough, I mean get more up with each cough, okay? That's improving the cough. Because if you have a lot of thick secretions and I give you some aerosol, now when you start coughing, it's going to be coming up better, right? Now, there you go, good. That's what you want, coaching them to get that stuff up, okay? Bronchial hygiene. Number 3, the number 1 difference between the two is to deliver what? Medications. We can use aerosol to deliver medication, okay? And number 4, of course, humidification of the artificial airways, right? Same thing. Artificial airways, I told you, some of them overlap. Some of them have, some of the indications for aerosol and humidity are the same, right? But there's a couple that are different. The major difference is you can deliver what? Medication with an aerosol, okay? Also, aerosol you can see, and humidity you cannot see, okay? All right. Now, what about the hazards? And this is the last part. Hazards of aerosol. We already talked about number 3, which was what? Fluid overload, right? You got too much fluid on them, you can overload them with fluid. We already talked about that. But let's look at the number 1. Swelling of dried secretions. That's number 1 for a reason. That's the most, that is the most adverse hazard that could happen. Is swelling of dried secretions, right? That causes airway obstruction and it can be fatal. All right, this usually happens in patients with a really weak cough, an unproductive cough. They can't get the stuff up. All right, so what happens with swelling of dry secretions is, I don't know if y'all remember those, you used to buy these little dinosaurs, and they was about this big, right? You can buy these little dinosaurs in a package. And they're about this big, little cute, little colorful dinosaurs for the kids, right? And you drop them in some water and come back the next day, and the dinosaur is big as the cup. Y'all remember that? You might be too young for sure. But those little, you know what I'm talking about? There's a little bit of dinosaur, or sometimes there's some other animal, right? It's just a little creature, characters that they have, and you drop them in water, and in about an hour or so, it absorbs so much of that water that it's bigger than the cup. It's coming out the cup. It's this big. Yeah, a little capsule or something, and you put it in water, and then they pop, they swell up to big as the cup, right? And that's just little, fun things for the kids. Well, that's what happens with swelling of dried secretions. If somebody has had dried secretions, because all the therapists before you, all the 2 or 3 shifts, this water bottle has been bone dry. You go in a room, they getting the oxygen, but the water is gone, and they didn't take the time to change the bottle, put a new bottle on there before they pass the patient on. And the next therapist didn't do it either. The next therapist didn't do it either, right? They've been analyzing the oxygen. It's good, satin good, but they didn't look at the what? The water. And so now you're drying them out, right? So then the good therapists come from Concord and say, damn, y'all, how long y'all, this bone dry, right? So you go and put a new bottle on the patient, right? Now you're putting water on those dried up secretions, and they are just like that dinosaur. Soon as the water hit them dried secretions, they come back to life and they swell up. All right. And if they swell up in the airway, what if they swell up in the trachea? What if they're there on the trachea and they start swelling up inside the trachea? It's going to block you off, right? It's going to completely plug them off, which can be fatal. Okay. And that's, if somebody who has a good productive cough, when it starts swelling up, they're going to feel it and start, right, and cough that stuff up. But a patient who's very weak from some illness, right, and it starts swelling up, they're going to plug off. Sat going to start dropping, and you ain't going to know why, right? And then, you see them, can't breathe, you're going to try to plug them, we'll try to suction them really quick or something to try to, it's called a mucus plug, okay? Plug them off. You can't breathe at all. It's like somebody just completely closed your throat because the mucus is there. It's blocking the trachea. You can't get any air past it. So swelling of dried secretions is the number 1 adverse reaction to aerosol treatments.
So what do we do in this scenario? So if we go,
You just have to watch it. You have to watch it. If you notice it's dry and you put on new water, you just need to know in the back of your head, they may be dry in there, right? And so you just have to watch your patient. When you put them on there, they ain't gonna swell like immediately. But if you see them starting to have a little trouble, you might need to go down there and suction them out. Okay? You'll go down and suction them out. You'll monitor as a therapist, just monitor what you need to monitor, and you'll be fine. But if you just slap it on them and then think about it and don't never check back on them, it's possible that could happen. Yeah, we don't want it to dry. So when you come on shift and it's dry, you need to tell them, did you change that? You need to change that bottle before you leave. And make sure you check on, make sure, because that ain't gonna happen in one shift, right? It ain't gonna get that dry in one shift, but it depends on how long it is. I really don't know how long it's gonna take, but just if you notice that it's bone dry when you get to the patient, then you need to make sure water is added. Either make that therapist do it before they leave, or if you don't notice it after they're gone, then you do it. But when you do it, just make sure you monitor, because if that patient, they don't have a strong cough, because that's one of the things you tell each other in reports. You'll stand by each patient and give reports. Right? This is Mr. Johnson. He came on such and such and such. He's weaning right now. His secretions have been this and that. He has hypertension, CAD. He had a CVA on such and such and such. His oxygen has been this. He goes back on the vent tonight at such and such. All this is what you're doing between each other. So it ain't gonna be just I walk into a room and don't know nothing about the patient. Right? You're gonna give a detailed report in handoff. Okay, so you already know he has a weak cough. You already know he has myasthenia gravis or some type of disease. And then you notice that bottle has not been changed or the trach has not been cleaned, right? You need to say, can you do that trach care before you leave? It's all about accountability. If you don't make them do it and you complain about it later, it's on you, okay? You should have had them do it before they left. If they act like they don't want to do it, then you go to the lead therapist and say, hey, she keep leaving these patients undone when I get them. And they'll reprimand her or they'll talk to them, make sure she does it, okay? So it's not about friendship. It's about taking care of the patient, okay? So if you notice it's bone dry, go fix it, right? If they don't fix it, get it done. Just monitor, make sure you look out for that, okay? Look out for that. Because if it starts to feel like if they, looking at them and they having a little more trouble and you're hearing it, go down and get it. Suction them. And that'll take care of it, okay? Water can cause a bronchospasm. Bronchospasm is this. This is a bronchospasm. When that trach, your airway goes from normal tone to this, that's bronchospasm, asthma attack, same thing. That's what this is. Can y'all see that on camera? This is normal tone. This is how your airway should look. When you have a bronchospasm, it squeezes to this. This is why you hear the, what's that? Wheezing. That's why you hear wheezing. Because she said whistling. No, she said whistling. That's why you hear the wheezing sound or the whistling sound. It's because they're bronchospasm. Right? The hole is small. You make your hole on your lip small, you whistle, right? And so they go from this to this because of hyperreactive airways. Some people's airways are just so sensitive. If they smoke a cigarette or somebody's smoking a cigarette around them, they start to automatically start closing up. Some people are very, very sensitive. So look at A, it says reactive airways. It should be overreactive airways. I'm gonna put over right here. Overreactive airways or hyperreactive airways. All right. So as soon as you put a little water mist in there, they close up. You're like, well, dang, I gotta give it to you. So with that patient, if I know they have very, very reactive airways, I may give them some albuterol treatment, breathing treatment, which opens you up from this up to this, called bronchodilation. And you're gonna learn that next when we get to pharmacology. After this is old pharmacology. And so now you're gonna learn about the medicines that take you from bronchoconstriction to bronchodilation. All right. And so if I know you have hyperreactive airways or asthma or something, not only will I give you the aerosol, but I might give you a little medicine to keep you from closing up on it. Okay. So those are things you do as a therapist. All right. So bronchospasm is the second hazard. First hazard is swelling of dried secretions. Second hazard, bronchospasm, particularly in your asthma patients or your overreactive airway patients. If somebody has asthma, sometimes they think, oh, please don't come. If you got on cologne or any kind of scented lotion, you can't go around them patients. They don't want you to wear no cologne, no scented lotion in the hospital because some patients are sick like that. As soon as you walk by the room, they go into a violent asthma attack because you got on Fendi, okay, or Chanel. So, you're a therapist now. You're making all this little money. You're buying the top now. You smelling good, and you get in there and kill somebody because you smell good. So you can't do that, okay? All that cucumber spice lotions and stuff that smells so good. Whatever that cucumber stuff y'all wear, I love that. whatever it is. It don't take much for us. It don't take much. A cucumber and then cotton candy and all that stuff. I love that. It smells wonderful. But you can't do it at the hospital. Okay, so if you're smelling good like that at the hospital and your hands have that nice smelling lotion on it, and you reaching around somebody's trach, changing they breathing it right in. They got a trach, and you messing with their gauze, changing out their gauze, or messing with the trach collar, right? They're smelling your hand right there by their face. That's why your fingernails have to be cut and level with your skin, because you're dealing with people right in here, introducing germs into their trachea by having long nails and having not having your hands clean, right? Make sure they're clean under your nails and stuff like that, because people looking at them right here, right? And they like, ugh, you know, you might have did a scratch off before you got to work, and it might be the stuff from the scratch off. You know, some people use their nails. Well, I do. I use my nails to do scratch off. Well, some people don't. I'm just saying it could be that, or you could have ate a piece of barbecue chicken or something. You know, the last little piece of chicken before you went to work, and some of that barbecue was under your nail, but they don't know that's barbecue. That look like doo-doo to anybody that's under the thing. After that, don't come back in my room. And you like, oh, that ain't nothing but a little chicken. I'm sorry, that was just a little, you know what I mean? But still, that's why you have to have clean hands, because you don't know what it is under somebody's hand. They're gonna expect the worst. You've been digging and scratching in your butt and got all of that on your nails, and you ain't wash your hands. Now you in here messing with my tray, right? So you have to be careful, because other people that see your hands, like you could be passing a piece of paper to somebody, and they're like, ugh. Right? And they never say nothing to you, but they already think you nasty. All right? So you have to be very careful in the hospital. You have to be very clean. Nails have to be right. Hair can't be super long, right? Don't want no hair falling in somebody's face while you're doing stuff. That's nasty. Okay? And not only that, but you're picking up their nastiness in your hair. Okay? So be very, very careful. Your name tag, rubbing all against somebody, pick up that C. diff right on your name tag. Then here you are using your name tag to get into another room and you eat. Boom, you got it. Okay? So be very careful. Fluid overload, number 3. Fluid overload. Usually use of high output systems with infants. That's usually the most person who catches that fluid overload. When we have a humidifier or aerosol that puts out a lot of aerosol in our small babies, they usually get the fluid overload the quickest, right? But your congestive heart failure patient or your pulmonary edema patient could also suffer from all of this water every shift, okay? So be very careful. And number 4, nosocomial infections. That's infections that are made or got from the hospital, right? Any kind of infection you get in the hospital is a nosocomial infection, and they're can be caused by cross-contamination. Okay, so I'm messing with his bottle, messing with your bottle, and not washing my hands in between. That can cause cross-contamination, nosocomial infection, right? Or, you know, it's just because it's liquid and it breeds bacteria, so it can cause that. All right, those are the 4 hazards of aerosol. Sweat and dry secretions cause bronchospasm in your overreactive patients, fluid overload, and nosocomial infections. Okay. So go back over those notes really well. Tonight, test was your homework for tonight, was your test that you took. So everybody has attendance for today. So I'm going to, tomorrow, I'll probably add some homework to it for tomorrow night. Tomorrow when we get here, we're going to talk about humidifiers and nebulizers, the Passover, the wick type, the cascade, spinning disc, all these different types of humidifiers. Start noticing the humidifiers when you go to Walgreens. They're going to start putting them humidifiers out, right? When they're on the front shelf and on the end caps, because it's getting to be cold outside. And the colder it is outside, the less what? Potential for humidity, right? The potential goes down. And since the potential goes down, it makes the room drier. Everything gets dry, and your lungs get dry. So we have humidifiers to moisten the room back up, okay? That's why they start selling these humidifiers in the wintertime, because as the temperature goes down, the potential and the absolute humidity go down. And you have to replace that with a humidifier, okay? All right. So we'll talk about that tomorrow. Have a good day. The whole unit, the whole module is open for you. So if you want to look at the PowerPoint, you want to look at some other things that's in there, look at it, okay? Be ready for tomorrow. Have a good day.